Great. So I'm Rob Stewart from King's. I'm chairing the first part of this afternoon. And very pleased to welcome Aideen, who's going to talk about exploring the efficacy of administrative data and research from Northern Ireland. So Aideen is a psychiatric epidemiologist by training, currently a lecturer in social epidemiology within the School of Medicine at Queen's University Belfast, co-director of ADR Northern Ireland since the passing of our very good friend and colleague Dermot not that long ago, and it's great that Aideen has sort of been able to take this on. So she runs a team of research specialists within ADRC Northern Ireland and Queen's University Belfast and Ulster University. I'll hand over to you now.
Thanks, Robert. Thanks, guys, and thanks for the invite to speak here today. Like mentioned, I'm going to speak to you about the efficacy of admin data into mental ill health research in underserved groups. Hopefully you all know what administrative data is at a data science conference. We'll not go into that. And also hopefully you're all aware of what mental ill health is and how we can define that. But underserved groups is sometimes difficult to define. So I'm just going to speak to you a little bit about what I mean by underserved groups. So who are these underserved groups? When you think about it, you may think of obvious ones like migrants, the homeless population, individuals from the LGBTQIA community, individuals or people of colour or ethnic minorities. But underserved groups are also individuals living in rural areas, living in poverty, older people, people with a disability, and small little sub-cohorts like Romani or Irish travellers, pregnant people, and also individuals with mental ill health themselves are underserved. So trying to understand mental ill health, an already underserved group, in underserved groups is somewhat difficult. Why do we define these individuals as underserved? Well, the main reason is a lack of inclusion in healthcare or research. There are barriers to individuals being involved in research in these groups, and also barriers to their inclusion in the uptake of healthcare services, whether it be due to cultural differences, language, stigma. There's important differences in how they engage. And these individuals tend to have a higher healthcare burden themselves. So there's high rates of comorbidities in underserved groups like individuals from low socioeconomic backgrounds. But when we define underserved groups, we also have to be context specific. So although we think of all of these groups as individuals that can be underserved, we can all be underserved in particular contexts. So where gay men may be underserved in education research, they're overrepresented in HIV/AIDS research. Why should we care about these underserved groups? Well, the thing is that policymakers are often interested in the majority, not the minority. And rightly so. If you're a policymaker and you want to make a wide sweeping policy change, especially in the area of my area, which is public health, they tend to be, where can we get the biggest impact for the most people? And that's usually for the general population. And looking in particular at small underserved groups is more difficult because then you have to get into more specific interventions. Why should we care about this? Well, it's a matter of inequality. So in my area of research, the largest driver of the wedge of inequality is between the differences in mental health outcomes in individuals who are overserved or correctly served and those that are underserved. It's an issue of equity that we should all be working towards. And in public health, when we think of public health interventions, I know you're not all public health professionals, but in your own area of research where you are developing interventions, we should be striving towards equity, where we don't just roll out something that's going to affect everyone the same way. We're going to target interventions so that everyone gets to reach their potential, or in this instance, see the baseball game. So we should be driving at least towards equity, where before we start at looking at improving population mental health for all, or at least in parallel with it. Whilst the majority of research, whilst the majority of public health interventions so far are sort of targeted at the whole population, COVID-19 was highlighted the issues of increased or multiple risk in underserved groups. And we highlighted the fact that individuals from different groups are affected differently by the COVID-19 virus. So we saw higher rates of poor outcomes by ethnicity, by socioeconomic status, by age. And all of this research was done using administrative data. The UK research that focused on differences in COVID outcomes based on ethnicity was done using administrative data, census-linked data. So administrative data poses an excellent resource to do research into these underserved groups. Is it the best approach? We'll discuss a little bit about that today. The other approaches include things like surveys. But the barriers to involvement in healthcare in underserved groups are also the barriers to involvement in these standard types of research, where if I post a survey out to everyone, the individuals least likely to fill in that survey are those from underserved groups, are those with poor mental health, are those from lower socioeconomic status, are those from non-English language speaking households. So administrative data does pose a positive pipeline to do this research. And why? One, it's a large size, it tends to be population-wide. Two, it removes those barriers to inclusion because it's to do with interaction of services, not getting you to interact with research. It can detect small effects if the population size is large enough, and it's easy to access. This is what we say when we're selling administrative data research to people who don't do administrative data research or to funders. In actuality, yes, it's large in size. Does it remove barriers to inclusion? Like I mentioned, the reason why individuals don't get involved in or don't interact with services may also be the reason that they don't engage in research. Can it detect small effect sizes? Only if the individuals we're interested in are actually in the administrative data. And some really underserved groups or particularly hard to reach groups may not be identified in our data sets. And I'm not really sure we can say administrative data is easy to access. I don't know what your administrative data journeys have been like, but some of the research that I'm speaking about in this presentation took about 4.5 years to get access to the data. Once we have it, it's very easy to analyse, but the pathway to getting access is sometimes long. So I'm going to speak briefly about some of the research that have been carried out in Northern Ireland using administrative data, in particular in underserved groups, and to highlight some of the sort of strengths and limitations of that and what we've learned from what we've done so far. First case study I'm going to discuss is a programme of work looking at the mental health of children known to social services. Children known to social services are an underserved group in research and in interaction with mental health services and healthcare services. The data sets involved in this were social services data, primary care registration data, death records, prescription medication and hospital admission data, including presentations to emergency department for self-harm. And we wanted to ask questions around the mental health status of children known to social services and also the sort of longer term outcomes in young adulthood of individuals who are known to social services in childhood. Now we use the term known to social services because this administrative data set allowed us to gain information on everyone who was ever referred to social services. Now, most research in this area looks only specifically at looked after children or children in care. So this would be the standard thought of children who are removed from their home and placed in foster care, kinship care, or residential care. But when we look at administrative data, we can look at everyone that was referred and deemed not in need of services and had no further action. Those that were deemed a child in need remained in their own home and had some sort of interactions, and that more standard, smaller group of individuals who are removed from the home and placed in what we would think of as standard care. And the results look something like this. We were able to look at all young people in Northern Ireland, so all 500,000 or so individuals aged 18 years and under or 17 years and under in Northern Ireland. We looked cross-sectionally at one time point in 2015 because it was the best quality data. And what we found was that over 1 in 6 children aged less than 18 years in 2015 were previously or currently known to social services. This number was much larger than we thought, because all of the research that looks into sort of children known to social services in the standard looked after or child in care format is a much smaller number. But whenever we look at this underserved group, is actually quite a large proportion of our young population. And about 1 in 20 young people were currently, at that time, known to social services as a child in need or a child in care. So that's at least 1 in every classroom. But as we know, that's usually a lot in one classroom and none in some classrooms. So did we have large size? Absolutely, we had the whole population. And everyone who ever interacted with social services is included in this because it's an administrative data set. So it did remove some barriers to inclusion. Our results when we're looking at a range of mental health outcomes, like receipt of antidepressant, anxiolytic, antipsychotic medications along the bottom, ADHD medications, also psychiatric hospital admissions, presentations to self-harm, showed this sort of stepwise increase in poor mental health as interaction with social services increased. So we see the little red line, the light red line is never known to social services, the dark red is known as a child in need, so that's an individual that remains in their own home, and the gold bar is individuals that are removed from the home and are a child in care. And we see that individuals who are in care had 10 times the rate of antidepressant prescribing, 50 times the rate of antipsychotic prescribing, 25 times the rate of self-harm. This is the first time we've been able to look at this for the entire population. And what we found most interestingly is that although children known to social services represent about 1 in 6 young people in Northern Ireland, they account for 1 in 2 of all children with poor mental health as measured by our indicators. So were we able to detect small effects? Yes, this is quite a large effect, but also within this we were able to look at subgroups of this population, that population of individuals that have never been addressed before in research, those that are deemed not in need. So these are individuals, like I said, that were referred to social services and no further action was taken. They had an equivalent risk of poor mental health to those individuals that were deemed a child in need and interactions or interventions were introduced. So these children have some sort of need, perhaps not a need that is delivered by social services, but they're a group of individuals that can be flagged as a potential new underserved group, someone we should be looking out for. And when we look at mortality rates, we see they have similar mortality rates to the children in need, more than those that were never known to social services, and the same is true for when we look at deaths by suicide. Was the data easy to access? Relatively. But I'm looking at this with rose-tinted glasses. It's easy to access when I talk about it now because this was 4 years ago and I've forgotten all of the trauma because we have COVID in the middle of it all. It was not easy to access. It took a very long time. And there were issues. We had data completeness challenges. This was the first time that we'd looked at 30 years worth of social services data in Northern Ireland for research purposes. And what we found was that data episodes were missing the unique ID for linkage. So unique ID is health and care number. For every interaction a child has with social services, they have a new record. So some children may have 4 or 5 records, some children may have 300. Some of those records were missing the ID. What we found was that in these different modules of data sets, we had up to 20%, 25% of records missing an ID. Now we don't know if that relates to one child who's missing their ID for all of their, 200,000 records, unlikely. So we're definitely missing some children here in some episodes. When we compared the numbers in our data set to the national statistics that are reported annually, our numbers differed greatly each year. Right down to at some points, our data set only seemed to capture 50% of those that were reported in the national statistics. We're not quite sure which is the correct number, but we do know for sure that we're missing some individuals because of that lack of unique identifier. We have measuring mental health challenges. We measured mental health as receipt of psychotropic medication, presentations to hospital or admissions to hospital, and looking at cause of death by suicide. These first 2 measures of mental health require an interaction with services. We miss all individuals who receive alternative therapies. We miss all individuals who have poor mental health and don't interact with services at all. We don't know what we don't know for this group. So, was it the best approach for looking at children known to social services? In terms of a large size, absolutely. We're able to capture absolutely everyone that was referred to social services in Northern Ireland. Does it remove barriers to inclusion? It's questionable. We do capture everyone known to social services, but when we're looking at our outcome measure, we still have those barriers to inclusion. Were we able to detect small effects? Somewhat, but we don't know what we don't know. And was it easy to access? Easier than other data sets, but not easy. Another case study that we're looking at is the identifying mental health by what we'll call Section 75 categories, and this is using the census. The next couple of case studies I'm going to run through, we're still awaiting results for, so they'll be much quicker than the last one. But this one, we're looking at the 2021 census and identifying a range of different Section 75 characteristics: religion, ethnicity, age, marital status, sexual orientation, language, Irish language ability, English language ability, Irish traveller, and mental health, based on the question we have in the Northern Ireland census, which asks, do you have an emotional, psychological or mental health condition, for example, depression or anxiety? We're also linking this data set to mortality data. From that, we can look cross-sectionally at the mental health of a range of underserved groups. Self-reported mental health, but still we get a look at this massive range of underserved groups. We want to look at what's the mental health status of the population, how do they vary to those that aren't in these Section 75 groups, and is mortality risk mediated or moderated by mental health status. We're awaiting data access for this, so that data is easy to access. It's questionable. It's approved, we're just awaiting the data. We had some data access challenges. 100% census is not yet available, we're waiting for that. We have data completeness challenges. Again, who doesn't complete the census? It's individuals from these underserved groups. And we have the fact that it's a self-reported mental health challenge. So in terms of this project, yes, we have a large size, but we're probably missing the most important people. Therefore, it doesn't really remove barriers to inclusion. We're not really sure if we can detect small effects yet. We can't with the Northern Ireland longitudinal study, but we'll wait and see how we get on with 100% census, and it's definitely not easy to access. Third case study I want to look at is mental health in the houseless population. So in Northern Ireland, we were able to look at housing executive data on applications for housing from individuals identified as houseless. Individuals, couples and families, we can look at the sort of different subsets within that. A link to the usual plethora of primary care data, death records, medication data, and interestingly in this one, social services data, as there's a strong link between leaving care and becoming homeless. So the usual standard questions: what's their mental health status? How does this vary? Can we identify any particular predictors of houselessness? We have data, it's being cleaned, but we have no results for you yet. Within this data set, we do have large size. It's everyone who has applied to the housing executive. However, it's only those who have applied. It's not all homeless or houseless people. Does that remove barriers to inclusion then? Somewhat. Who wouldn't apply? Who are the individuals that we're missing? Can we detect small effects? Hopefully, yeah, we have a large enough size. Is it easy to access? No. This is the first time we've partnered with the Housing Executive in Northern Ireland to deliver this data. This is a pilot project, and we're going to see how it goes. We're working with the partners. It's the first time they've shared this data. It's not readily available as a standalone data set for researchers in Northern Ireland. Brings me on to the fourth case study, which is similar to the last, which is looking at mental health in the prison population. For this, we have healthcare and prison data. So in Northern Ireland, the Southern Health and Social Care Trust is responsible for all healthcare in prisons in our 3 major prisons in Northern Ireland. They hold the data for every individual that attends prison, shall we say, and their health care needs when they're there. What medication they're on, do they end up in the hospital infirmary, have they ever self-harmed? They get all of that information along with information on their reason for incarceration. We link this to the standard primary care data, death records, prescription medication data and hospital data that we use as a standard in Northern Ireland as indicators of mental ill health. Asking similar sorts of questions about the mental health of this population. The data just arrived last week. So no results for you yet. But this has taken about 2.5 years to get this data, so it's quicker than some of the other data sets, but still a long period of time. Do we have a large size? We have everyone that was ever in prison. Yes, they have to be in this data set. Does it remove barriers to inclusion? In terms of identifying prisoners, yeah, because it's all prisoners. Can we detect small effects? We won't know until we have a little look at the data. And there are outcome problems. Again, we are using these proxy measures of mental ill health in terms of medication and presentations to hospitals. Easy to access? Absolutely not. The same as the last project, where this is a pilot project. Built a relationship with the data custodians. We're using this data for the first time. The hope is that then it becomes readily available to all other researchers, but for now, it did take some time. So what lessons did we learn from all of these projects? The good, we can identify groups that would not normally take part in research. We absolutely can for administrative data. We can get whole populations. We can get all prisoners. We can get all children ever known to social services. We can identify new underserved groups, like those individuals that are identified as not in need, and potentially more from the data sets that we're just beginning to do analysis on. And we have engaged with new data providers. And new data providers have engaged directly with us and are super keen for us to utilise their data to answer questions about underserved groups. The bad, barriers to research are the same as barriers to admin data inclusion. Data completeness is an issue, like we've seen with the social services data, and remains to be seen with the likes of the prison data. Outcomes is a massive problem. How do we measure mental ill health? How do we measure mental ill health at all with administrative data is a major problem. And time. Access has so far taken a long time for all of these data sets. What I haven't mentioned so far is the missing piece. We're talking about the data sets here, and we're talking about the numbers that I can give you and the results that I can give you, but behind that lies the individual and the individual experiences and the individual context. Individuals' experience, emotions, beliefs, cultures, everything that we can't identify from administrative data. All of these things that are super important when it comes to examining mental ill health outcomes. How do we overcome this? The message is include us. Include the people behind the numbers. So we've learned to involve experts by experience, but also to involve the data providers. We all know that anyway. And to involve those who create the data. So people are actually inputting the data. Sometimes the data custodians who hold the data aren't the ones that are sitting on the front line working on the interfaces all the time, and we need to involve them too. So what next? The message basically I want to say is, of course, we can use data to understand mental health in underserved groups. It's not perfect, but what research is. Involve experts by experience. And the best way to ensure that we're getting the best indicators of exposures and outcome is to use multiple data sources. There's more data out there, and we need to be able to ease our access to this. The fact that all the data sets I spoke about took many years to get access to is because the legislation doesn't exist in Northern Ireland in particular. So there's a need for the secondary uses of data legislation. Don't worry, we're pushing for it, and we'll get it soon. And when we do, we'll have to raise a glass to our friend Dermot O'Reilly, who unfortunately passed away early this year, as Rob alluded to, who was involved in all of this research. So happy to take any questions. I think I went a little over time there.
No, thanks. It's fine because we can move into the panel and sort of it'll merge a bit, I think. Anyway, I guess while people are thinking of questions, I mean, one of the kind of, I suppose, sort of tedious administrative things is kind of how you structure an academic department to deal with these timings. Because I remember when we began dipping our toes in data linkages, I can think of a few poor research fellows who sort of began their fellowship saying, I'll set up a linkage, we'll analyse, and and they were at the end of their fellowship and it was still only just beginning to be set up, and they never got to produce the results they wanted to. And I've sort of warned people very strongly against basing fellowships on new linkages unless the data are in place. But then you need really a sort of long-term staffing structure to kind of create the relationships and make the. How do you think that works?
I think in Northern Ireland we definitely made those mistakes early on as well, where we had poor PhD students and postdocs in positions where they're 2 years in and have no data. And we've learned from a practical standpoint that every project has a plan A and a plan B and a plan C. and every project has an aspect that's safe data and new data. And if you get the new data, great. If you don't get the new data, you've at least got the safe data to work on. In terms of the sort of longevity and building relations, I mean, in Northern Ireland, we're a small team and that team's remained pretty constant, and you just have to have a little bit of perseverance and chip away all of the time. But in terms of the problem we see is that it's the individuals on the other side, not the academics. So you create relationships with data custodians and government organisations, and then they move on. And then you have to resell yourself again to the new person, and then they move on. And then you resell them again, and they haven't heard about the thing that you've been working on for 4 years, so you're back to square one. So I'm not sure that the problem lies at the academia side, but more on how we sort of tackle that from the data custodian side.
So sort of building on what you just said, so I lead the mental health part of ADR Wales. So there's the getting the data bit. So I lead the Wales ADR work stream on mental health. And there's that first bit of getting the data, and then the whole point of ADR is then to work really closely with policymakers. And those are two different groups in government. How much success have you had translating your findings?
Varied success, and it's more a matter of finding an interested party who's engaged. And I'm not sure that there's been anything to do with our strategy, but more to do with the luck of the draw, and that the right person at the right time is there. I would like to say we've cracked it and we know exactly what to do, but that we have been persistently reaching out to policymakers. Partners in the Department of Health have been most receptive, especially around the children known to social services research. It's informed strategy documents, many strategy documents. We've written policy briefs. We're involved in the Children's Social Services Review. There's been lots of policy interaction with that. The homeless project is also, we have super interested policymakers who really want to make a change and enact a change, hopefully based on the outcomes of that research. But the ones that aren't interested and don't get it, don't get it. And I don't know whether it's that they don't get research at all or they don't get administrative data research. So we haven't yet overcome that. We've had some success, but I think it's more to do with the right people being there.
And how joined up do you think the 4 nations are? Because so we've done, similar work on social care and care experienced children, but through the Family Justice Observatory partnership. And suddenly I'm thinking we're all doing these bits of work that are exactly the same, but all facing in different directions. So it's a question to me as well as you.
Yeah, we're not very good at a 4-nation approach, and I think that all the will in the world is there, but there are limitations with the data sharing in that the Northern Ireland data stays in Northern Ireland for now. We have very limited data that's made available on a server. COVID, we were able to bring in UK SERP for some of our health data, which is fantastic, but every other data set, you have to be in Northern Ireland to access it. So there's barriers to collaborative research there. There's barriers to collaborative research because what I mean when I say a child known to social services through the way we have recorded it is different to in England when they use a school census, is different to Scotland, Wales. So how much can we do comparative research? Are we comparing apples and oranges, or are we happy to say this is the fruit bowl and we're saying these people are all broadly similar? I think we need to do more of it, but it won't be perfect either. I don't think it's as easy as we all need to do a UK-wide approach.
It's also timing, isn't it? Because one of the things we were going to do in DATAMIND was the prison work and do a comparator, but we got our data a lot sooner than you. But we got a smaller...
It's showing off now.
a smaller...
It's not a competition.
A smaller section of it. So it's really tricky doing 4-nation stuff outside CPRD, really.
It is, but again, also, I think there needs to be an understanding about that timing issue and the fact that the four-nation thing may happen later, and that should be built into the work packages that we're writing. We're not going to do a comparative piece of work in parallel, but there should always be that flexibility in our large-scale grants that we have, like DATAMIND and ADRC, where if and when the opportunity arises, because we realise we have finally got the data that these three guys have had for ages, let's do some research then. But I don't think we have that responsiveness built in, and that's probably something we need to consider moving forward.
Question from Jay, and then I think we'll move to the panel.
Thanks. Really nice presentation, thank you. Really interesting to hear about your co-production approaches towards the end. And my question was really about that. So where we've also worked with people with lived experience to inform upon, kind of data science or other sort of very research-based kind of work, we've had to do quite a lot of capacity building and almost training in order to ensure that people are able to kind of meaningfully be involved. So I wondered if you could say a little bit about your approaches. And I guess related to that, because it is so important in terms of this field, I suppose this links back to Rob's question. I mean, should this be something that's almost part of infrastructures where we're doing this kind of work so that everybody can sort of benefit from it, this kind of involvement as a resource, including PhD students and people earlier on who aren't necessarily with big pots of grant money?
Yeah, absolutely. And I think that the expert by experience model that we've done in ADRC Northern Ireland, we piloted that with the Children Known as Social Services group, and we're now rolling it out with the homeless population group, and the same for individuals who have experience of being in prison. So prison group we haven't started yet, the homeless one we've just started, and we're trying to take lessons from our Children Known as Social Services group and apply it there. Absolutely, there was need for some capacity building. When we were working with young people, I think we took an approach that was just informed by our own gut instinct we need to take a little bit of a softly approach and not be like, here's administrative data research, there's everything that we've used, here's our data sets, but to sort of piecemeal it and be like, here's a little bit of data that we've used, this is what admin data is in our first workshop, what do you think about admin data, what do you think about us using this? The second workshop, let's look at this one set of outcomes, what do you think of that, how can you feed back to that? Third workshop is we're doing some new research, what do you think those questions would be? I mean, there's definite need for capacity building in terms of getting the experts by experience up to speed on what administrative data research is, but more so I think for the researchers delivering these workshops who occasionally have no experience of working with the publics. And some people are very good at it, naturally, and some people aren't. And our comms and engagement manager at ADRC is doing a training capacity building program to train individuals how to work best with experts by experience. The hope is then we can roll it out among our researchers and it becomes a standard. But it's difficult. I mean, it's a difficult undertaking. But we're trying to sort of conceptualize it into a training package that will be available, hopefully, to everyone to ensure that we do more of that. Not sure I answered your question.
Great. Thanks very much, Aideen.
Thank you.
So we're going to have a really smooth transition here. So Aideen, we'll have the panel up on the high chairs here. Aideen, Andy, James, Jay, and other James, I think.
Can I keep my microphone on?
Don't be the loud one.
And I guess we may need a microphone to kind of move around. Sorry?
No, I need a small chair.
Be like a domino rally.
This is for the panel, so I'll put it in the middle and then give
I
this
have
to
one.
Ryan.
Yes.
I think I have one.
Okay, thank you.
So you've obviously met James, Andy, and Aideen. Jay, you're going to be introduced later, so but Jay's from King's, a colleague of mine. James, do you want to say
sure.
say who you are?
Yeah, I'm an ambassador for MQ, and I am here in the capacity of lived experience, but also do bits of research. So I was very interested by the last bit of your talk and thinking about bridging the gap between the identities of researcher and person with lived experience, because sometimes they do overlap, don't they? So yeah, that's what I'm here to talk about.
Great, okay. So what we're going to have is a panel discussion, and the title is Getting the Social Perspective into Mental Health Data Science. And it would be really great if this was a discussion with everyone here involved, but I'm aware that you may need to do some thinking, some questions. We came up with some slightly pre-prepared ones, which I will introduce at random. So I suppose kind of sort of kicking off on this, do you think that social and biological measures can meaningfully be integrated in data science research, or is this just an aspiration to keep funders happy? So, you know, we'll talk the talk, social, biological, bringing it all together. I mean, really, does that happen, or is it just some sort of gloss on a grant application? I wonder whether, and James, do you want to start off with that? Because, oh, sorry. Well,
okay, am I being thrown under the bus? I don't know. So I suppose coming at this subject, I think in general I was thinking, what on earth am I going to say about data science? Because I'm not a data scientist, and I thought, like, well, you know, racking my brain for what I could usefully say, and then I thought, actually, maybe that's the point. Like, how is data science relevant to somebody on the ground who might be struggling now or needing help now, and maybe even in the past needing help? So I guess the question that sort of went a little bit over my head, the word that stood out for me was sort of the meaningfully part. So what is it that makes collecting any measures meaningful? And maybe it's sort of scientifically interesting to work out like what mechanisms are going on in something from like the researcher point of view, but actually what's meaningful for the people this is supposed to benefit is the part that I want to have sort of at the front of the conversation. And yeah, so I don't know whether we integrate biological and all these and social measures, but I think that I'm just thinking about what would make it meaningful, really, and always referring to the people who it's supposed to benefit.
James, other James?
So I'm going to throw the question back at you, but say, well, what would happen if we don't integrate the social and biological data? And what will happen then, I think, as has happened to an extent historically, is that you'd get separate fields, you'd get polarization, as we know can happen when people don't speak the same languages. And I think advances in science rely upon interdisciplinarity and people working together, typically. And so we've got to do it. It's not an option, I don't think. But also it makes complete sense. If we think about how the conditions that we're interested in develop, then it is almost always a combination of social and biological risk, for instance. And so not to have those integrated will constrain us in a way that will really put a brake on the way we advance. So we have to do it. It's an imperative, I think.
But how does it actually work?
So
For a biologist like yourself, how do you make that happen?
So getting the data together is, I hesitate to say trivial, but as I said earlier, genomic data is really simple. And there are... No, it really is. I mean, all it is, you know... Pardon? Well, exactly. But as far as manipulating the data goes, then it's simple enough. You know, the compute and storage requirements aren't simple, although as an initial step. So we've worked with Sail to download data that doesn't occupy a lot of space on servers at all. It's things like polygenic scores and copy number variant calls initially. So I think to do it incrementally like that is the way forward. The other thing that is a challenge is that the analytic infrastructure for these shared resources needs to be designed to be able to to allow biological analysts in, if you like. So to have the capability of running software for sequencing data like Hail, even things I've spoken already today about having Plink available, so having genomic analysis software available. And then if you get that, you'll get people interacting, you'll get PhD students jointly supervised, and things will develop from there, I think. But it's probably the case that people from a more social angle are fearful of the genomics. It's also the case that geneticists will typically be really scared of the social data, just from a point of view of ignorance. There's also I mean, I hesitate to say this, but there is a sort of will I go
It's a
there?
safe space.
There's a sort of political angle to it as well, I think. So I think people would be surprised that a lot of people doing genomics research actually come politically at things from a very similar angle to those that are coming from a social sciences or social perspective. But that is also that, you know, there are emotive connotations of genetic research that often people coming from a social science background will be very aware of and cautious about. And those of us in genomics research have had to confront this repeatedly, and it's not pleasant often, but it's a requirement of the job. And again, it's only through working together and educating the wider public about those things that I think will overcome them.
Jay, you were wanting to jump in?
Sorry, I've broken the order. So I'm going to step it up and say it's not a nice to have. This is an urgent issue. We've known for decades that racially minoritized people have really adverse experiences in mental health care. Black African people 3.5 times more likely to be sectioned, detained, come in through coercive involuntary routes to care. So this is completely unacceptable. Same groups of people, much less likely to access evidence-based therapies. So this is an important issue because ethnicity and other protected characteristics are currently very poorly collected in healthcare data. It's not just about research, it's about what we're doing now and how we can use the data to improve the types of care that we deliver. There's a big initiative at the moment, the Patient Carer Race Equality Framework, just in England, I think. It's only in England. But data is at the heart of what they're trying to do. So they're trying to drive up the quality of data on protected characteristics because it's completely unacceptable. You know, we need to be moving away from yet more observational studies that just describe these inequities towards putting this data to work to improve the quality of the healthcare. So that was the kind of point I wanted to make. It's not just about research applications, it's about everyday practical use. And also I thought you raised a really important point actually about that kind of the barrier or the kind of gap between the politics between genes and environment, which is so backward and old-fashioned, isn't it? Because if we could bring these data sources in, we can start thinking about gene-environment interactions, polygenic risk scores. Some of the best work is coming out of some of our Nordic partners who are doing some brilliant work, and it really takes this step forward. So that's what I wanted to say to that.
Can I just say something really quickly, Sam? That I think I understand the question a little bit more now, and I think that this idea that it would be an either-or just doesn't make sense when you think about the nature of illness. So the area that most of my lived experience is in eating disorders, and we don't really collect outcome data in services, and this is a big problem. And the evidence base is on a very sort of small group of people out of those who are affected, and we don't look really at the demographics. It's not even collected in a lot of, or reported in a lot of research. And so we thought this is a huge issue and set up the Eating Disorders Clinical Research Network, which is based at King's. And there's also work there on a big genetic study, which people seem to be sort of less enthusiastic to get involved with the genetic study than with but also the idea of sort of being involved with data and what does that mean for me as a patient or me as a clinician. I think a lot of this like divide is just maybe ignorance. I don't want to say that finger pointing, but just sort of an unfamiliarity with like, well, we don't routinely collect data. What is this about? How do we analyze it? How is it going to be useful for the so many people who are coming through the door needing help? And I suppose asking, like where I come into that is, I think this is maybe a bit of a solution to that question that you were asked about including lived experience, that maybe a member of the team could be somebody with lived experience brought in a sort of employed kind of way to bridge that gap, and then sort of skill the rest of the research team and facilitate the focus groups and that kind of stuff. So that's what we've been doing, and asking people, well, what kind of data do you think is important for services to collect as an outcome to measure recovery? And when you ask that to people, it is obviously biological and social and all of these different things, and really can't be separated, and that's reflected down in people's care, isn't it? That they experience care is very siloed between gastroenterology here, psychology over there. They don't really talk to each other. They often say different things, and I do think that data and the knowledge creation part of it is the essential part of it, but it's sort of seeing, I think when you start to see some more results in the field of eating disorders, at least, like actual outcomes of collecting data and using it, I think that will encourage people to buy into it a bit more. Because at the moment it does feel a bit abstract and kind of remote. Like, we know we should be doing it, but how does it help people?
Andy, Aideen, you want to?
Yeah, I want to add a more positive spin to it, because we've looked at a few challenges, but the longitudinal world has long been a centre of focus on interdisciplinary research. I think prior to the pandemic, there was an organisation called Closer, which is designed to bring cohorts together and work in conjunction. Prior to the pandemic, we were probably still talking along disciplinary lines in a slightly different language, looking at things through a slightly different perspective. But during the pandemic, I mentioned earlier, there was an initiative called the National Core Study. And that really showed how you can do this properly. So we had the longitudinal health and well-being, which was an explicit name mentioning both social and health issues. And it was an interdisciplinary team. And that was my first learning, is if you're bringing together complex data from different sources and disciplines, you need domain expertise in those sources. So it's team data science. You can't expect a disciplinary expert group to have expertise across all data types. That's just not realistic. So it needs to come together as a true collaborative group from onset with expertise across the range of data sources you've got. And we've got some great examples of that. One of the other national core studies was about transmission of COVID in the workplace as a huge risk factor. And that's now leading into a huge program of work looking at occupational mental ill health and how that's influenced by workplace stress and background factors. So again, thinking interdisciplinary from the beginning, bringing together experts from the mental health arena, the occupational health arena, and the social scientists. So I think there are really good examples of this starting to work in practice, but only where you got team data science.
I agree. I don't really have much to add apart from the answer to the question is, should we be doing it? Yes. Can we do it in a meaningful way if we play well together? That's it.
And how, I mean, we've obviously heard in detail about ADRC and the Northern Ireland sort of setup. I mean, how is the biology in that?
No, is the short answer. And the genomics research is very separate, kind of under HDR UK, than the sort of social data, which is under administrative data of ADRC. And the two paths don't cross. There's lots of intent to do it, and then people are overwhelmed with workload, and it never happens. But I mean, I think it's having the right interested parties and the motivation to do it, which is why we need to play well together. And that fear of the other side's data, I think needs to be allayed by, we're not expecting the biologists to be social scientists or the social scientists to be biologists. You come with your expertise and you work together.
And James Waters, any lessons from Wales as to how that sort of integration has been helped, bringing disciplines together? How do you?
I mean, I think we're here as demonstration of this fact as well. So various people have come up to me in lunch and coffee breaks who've got a background in genomics, but are actually at a data science meeting. And I think this manifest in that really is that it is happening, but we just need to ensure that it continues to develop. The only additional point I was going to make, thinking about the administrative data, is that there are some ethical considerations around genomic data being linked with data from the judiciary or that kind of thing. So, and I think to have ethicists as part of those discussions, if we're doing it with large-scale administrative data sets, will be sensible, because it's not something that we necessarily are best placed to decide.
So, and those from the floor, please wait for the microphone. I've been told from the back.
So adding up to what you said, I did study in Dundee, and I had access to the Go Fusion database, which had both social data and biological data. So it was durable. It's durable because it was done there. And for us to merge or link the data, like you said, there was Plink. So all we had to do was use Plink to extract the gene and then match them to the phenotypes. And it was used to predict, risks of diseases. And that's durable. And it was being done. So I think in mental health, it can be achieved as well. Yeah.
Yeah, I mean, I want to echo what people have said, that I think it is being done, and where it's possible to do, people are jumping on it. I recently reviewed all 450 mental health papers that have come out of UK Biobank. And I wouldn't say UK Biobank is the best place to go looking for social determinants of mental health, but it's not that bad. And about half the papers are using genetics to look at the social determinants of mental health. It's just extraordinary. When I read the first one, I was like, this is nothing. But you actually look at it, the way that they're trying to structure causality using the genetics. And as long as it's not kind of overblown, usually it's set within the context of a lot of other evidence. I found it really useful. So I think people want to do it. If they get the data, they will do it.
Yes, I'll be there in a second. It's just a personal view of this, just as rather elderly psychiatrist now. I remember back in my training days, it was very polarised. It was biologists and it was social epidemiologists, and then they never met at all. And certainly at the Institute of Psychiatry, it was complete separation. Schizophrenia was a biological disease, and the biologists were having none of anything else. I think, I don't know what the historians will say. I mean, there was certainly the urban environment and schizophrenia risk, which came from longitudinal Swedish data. Glyn Lewis, I think, was one of the first to kind of publish on that. I think that began to kind of trickle down and sort of, well, if an urban environment is a risk factor, you know, that moves it away from just being birth trauma and genes. And I think possibly also the biologists realising there wasn't a single gene out there, which I think there was a sort of certain thought at the time. And then I think Caspi's paper on gene-environment interactions in depression and sort of life events and the serotonin gene, whether or not that's actually true or not, and people have debated it, but that idea of showing an interaction seemed to be quite important. And then suddenly everyone thought, oh yes, okay, we'll take it. So in response to the questions, things do change. It may take a career lifetime to see it, but it does happen.
I'm wondering about the impact pathways, accepting that if you have effective biopsychosocial research, sometimes you're going to find biological causal factors and sometimes you're going to find social causal factors. With the biological factors, there is a pipeline for resolving that. You go and talk to pharma, basically. Unfortunately, perhaps no one else is making biological interventions, really. Are we lacking a kind of comparable impact pathway for social interventions? And it always feels like we all know what so many social risk factors, but how you really start to materially address those, it feels silly to say, oh, it's simple, you just go and ask pharma to make a drug for your biological thing, but it's sort of a bit more direct in that way. So let me wrap that up. Do we need to be doing more for the sort of social impact factors, and what does that look like?
So, I agree that's needed, I think, but the pathway you go down causally doesn't necessarily determine the effective treatment. So, smoking is lung cancer is a biologically induced cancer, but the solution for it can be a behavioural intervention or a population health intervention. So we must be constrained by the treatment, by the cause, I suppose. But if we look at social causes of mental illness, then pretty much across the board we know factors associated with poverty, for instance, are real determinants of mental ill health, and those are political decisions, and so we've got to prioritise addressing those politically, I think, and perhaps we can be better advocates in that regard.
I think that it comes back to where you were ending earlier about policymakers and communicating with them, and some are interested and some aren't, and a lot of these things are very political, economic things as well. And at the moment I'm working on this project that's looking at ultra-processed foods and eating disorders, and like tackling that's a huge economic thing as well as a political thing. And like where, you know, having the data to say this is what an evidence-based policy would be is really hard. But I think then when you do have that, communicating it to the people who make the decisions about it, and you said that, you know, some people don't listen, I think that's somewhere where lived experience can really help, because certainly in my own experience of dealing with politicians, like, yes, they do want to see the data and the, you know, usually the savings that will be accrued by taking on your policy, but I think that they also do, some of them respond to the human case and the having that narrative as well, so not overlooking the usefulness of that, I suppose. Even if it can be written off as anecdote, it can represent like a broader group of people's needs.
Can I add to that? I think that's a really nice question, but I think I would sort of think about the solution, the pharmaceutical approach, as being essentially a kind of commercial determinants of our thinking, right? Because so much funding goes into those sorts of treatments. And actually, it's stealing my thunder a bit, but I'm going to talk about this shortly. There are very good complex interventions that are, you know, very much tagged to social determinants to kind of tackle the onset of mental health conditions. But there are very few that we know about, and they're complex and they're expensive to fund. But there are things that we can do, and I think we're at a very sort of exciting moment, I think, in terms of data science, because potentially we can also be using health records in a sort of everyday clinical context to sort of flag up points where clinicians could, for example, be reminded to ask about, sort of social factors that there are evidence-based interventions for. So if you think about psychosis and employment, for example, and there are some very good, nice guideline interventions that we know can help with that, but they're underused. And so I think it's a bit about rethinking this, because our thinking is very much framed by where the funding has come from, and has had a considerable impact in some of this.
Hi, I'm Jude Harrison. I'm an old age psychiatrist based in Newcastle, and I also work with Acrivia Health as a clinical advisor. It rather follows on from where the sort of discussion has gone, that we've got now incredible resources to be able to study things like social determinants of health. It does rely on us having research funding to answer those questions, though. And unfortunately, in this country, a lot of research funding is still one way or another from central government. And a government who cares about these sort of issues would therefore be very useful. And in our current climate, I'm not assured of that, given that I think the policy announcement from the last Tory party conference was that they were going to kick the woke out of science. I don't know what that means. I sort of hope that there will be a changing of the guard, and the more sympathetic people will come in. But it also applies to your research as well, that if you're working with government departments, they have to be invested in they have to get it, exactly as you said. So I'm not quite sure where it leaves us if we have a government that isn't sympathetic to, that doesn't get it and doesn't prioritise it.
My answer to that, I've mic'd up, would be that the onus is on us to some extent also, that we need to change the way we do things, and the standard format of academic research and publishing and creating policy briefs and all of that is good and important and ticks the boxes for funders, etc. But if we want to make impact, our pathways to impact have to be different. And the face of research now involves an awful lot of pathways to impact, which it didn't even 10 years ago or 20 years ago. And we have to be advocates for our research area and promote it to some extent. I think, it's not ideal, but we have to push it. So, I mean, thinking of innovative ways to get the attention of the people that matter is what I feel that we're putting an awful lot of effort into in Northern Ireland, and it's getting results. Small results, and again, based on is the person interested or not, but more than we did 10 years ago. And I think involving experts by experience, having a human voice to things is one thing, but we can't expect every government to always be interested in the things that we're interested in. It would be lovely, but we also have to, I think, put a little bit of the onus on us too. maybe nobody else agrees with that.
Sort of might move it on. I think. I mean, promising new developments. I mean, I think all of your talks have sort of talked about a bit about the future and about where you. But I think possibly thinking a little bit beyond your talks, where what could be really exciting for next generations to be working with, say, 5-10 years time. I appreciate you may need to do some thinking on that.
I'm holding the mic. I can
You're holding
go
the mic, Jay.
first, and then I'll pass it on. So I am going to talk a bit about this in shortly, but I guess, but just to kind of expand on what I was going to talk about, I feel like we're in a very exciting place in terms of UK data science, insofar as, there's UK LLC, there's some very large-scale linkages coming online, we've got health records, within NHS, it means that pretty much everybody's got a health record. And then we have many forms of linking into administrative and other data. And we've got cohorts and other types of very high-quality data sources. And I think the methodologies are just sort of starting. I think what's going to happen in the future, what I would like to see happen in the future, and I feel like we could go there, is we move towards putting this data to work to figure out what works to prevent and improve mental health conditions. So moving away from observational studies, but actually using observational data, but with methodologies that can enhance our causal inferences. So randomized controlled trials are the gold standard for evidence-based, generating the best quality evidence. And maybe that's another reason why we have lots of drugs that work, because you can randomize them quite easily. But the other stuff, you can't randomize as readily. And sometimes it would be unethical to randomize. And it's with the kind of promise of large-scale data and various methodologies, propensity score matching and Mendelian randomization potentially, and other approaches, we could get to a place where we can really start to understand what works to prevent the onset of mental health conditions and improve outcomes. I think we're a long way to go, and I think we were talking about this at lunchtime. It feels like there needs to be a bit of kind of capacity building almost amongst the kind of UK data sciences community, bringing in statisticians, economists, people from lots of other fields to really start to kind of develop those skills. But that's kind of where I think this stuff could go.
Yeah, I mean, I would completely agree. And just going back to the example of eating disorders, I think working out what works for who and when, I think we're very limited at the moment. And in some of the research work that I've been involved with, we're looking at how can we spread best practice and do quality improvement and things, and where there are sometimes barriers when we haven't done a randomized controlled trial. So and I think that being more sort of nimble with the different kinds of data that demonstrate outcome, and causal inference, to be sciencey about it, I think that would be great, because it really does hold us back from delivering the care that people need right now. I think some of the exciting stuff from just a personal perspective is how data and technology can help really capture some more of that phenomenological side of living with a mental illness, whichever one it is. So we rely a lot on self-report and people making meaning of their own experiences and this kind of stuff. And then that interpretation is then interpreted by a clinician, so there's a sort of double interpretation going on, and then it gets on a record somewhere. And then you might look at your health records like I have and say, well, that's not what I was going through at all, or not what I meant at all. So actually, I think sometimes, whilst I'm all for hermeneutics and this qualitative stuff, I think that a bit of hard data about like what's going on in this person's blood sugar when they're feeling this particular kind of way, like using technology for that could be really, really exciting and interesting. And that's just from my own experience, that I was having hypos for years and years and years, and always was just told, oh, that's just your mood swings. And then I started doing my blood sugar and realised I was having like quite severe hypos. So like things that can tangibly help people and help sort of people to understand why they're experiencing what they're experiencing, I think could be really useful. And in that real time kind of way, not self-report of like what happened in the week since last time, but actually seeing this is what was happening for somebody, even if it is like a mood tracker. That's something that's used now that wasn't used when I first was unwell. And there was only one other thing that I want to say about innovation, which is that I think it's sometimes quite difficult if you have been unwell for a long time, or you're not necessarily going to see the benefits of the research that you might be involved with or that you're seeing. That can just be quite upsetting in some ways. It's exciting, But I know that there are projects that I'm involved with that are designing like new care pathways and better services for people that like I won't ever benefit from that, or I won't have benefited from it when I needed to. So I think that sort of degree of sensitivity for people, like we want to shout about our innovations and like, you know, and rightly do that. But I think that we have to remember that a lot of people still are out there who won't benefit from it. And I don't have a big solution for that apart from really listening to people and validating them, but at least not leaving people feeling really left behind, I suppose. And you've got to start somewhere, and we tend to prioritise things like early intervention over long-standing, that kind of stuff. So it's sort of how do we do that as sensitively as possible, really.
So I'd agree. I think, you know, deeper phenotyping, getting momentary data, be that biological or social or activity measures, is going to prove increasingly important, and the integration of that with the other modes of data that we've spoken about. I think we will hopefully in the next 5 or 10 years move beyond you've got this diagnosis, therefore it's this treatment model, and we'll begin to get insights of, you know, a more stratified approach is what I believe could be early benefits. I think some of the other benefits are going to take longer than 5 or 10 years, but that is something achievable in the next 5 to 10 years. The other thing I wanted to say was just from if we're really going to transform the field, we need loads and loads of clever people working in the field. And so that's, if we were to spend our effort to come up with a strategic plan in that direction, would be great. And it's encouraging to see so many people here today, but we need to do that collectively. It needs to be with the voice, or probably driven by the voice of those with lived experience, but also from the academic community and clinical academics amongst that, because there's a real crisis in that area at the moment, and we're definitely going to need doctors and other health professionals to implement some of these findings in that time frame.
Thanks, James. But not thanks for pinching one of the things I was going to say. So 2 things. First should be near-term achievable, and that's AI in data discovery. Lots of data, particularly in the longitudinal field, it's too hard to find. So AI to tag and annotate data with keywords and ontologies, and AI to do question-driven searching, which makes sense. I mean, ChatGPT exists. Let's hook it up to really rich databases of metadata so we can drive that forward. So that's a near-term goal. The second is I've already made the point that I'm a firm believer in having tiers of data and information of different granularities and looking at the same question using data collected through different lenses. So the obvious area we're in the foothills of is smart data and smart devices. So this is sensors, digital footprint data like supermarket loyalty cards or social media posts, and to be able to really drive forward in that space to think about what the public are happy to see happen in that area, what safeguards they want, and then to build clever solutions which bring the public with us in terms of understanding of the benefits and also understanding of how we're going to keep their confidentiality and rights secure during that process, but then being able to make much better use of that really, really rich data in social media and in things like app use. And the other point I was going to make was about ecological momentary assessments. So you can just use these smart devices to understand people's feelings as they're coming on and off social media use, and also to ask policy relevant questions and get answers back really quickly, so we can be much more responsive to needs and topical questions.
Yeah, I think responsiveness is one of the things that I think we're getting better at. In terms of what I'm excited about for the next 10 years, I feel like data science and administrative data research has proven itself as a proof of concept. We're at a stage now where we're not fighting for this is an important area that we should be looking at. I feel that there's been a bit of a shift change in, yes, this is something we should do, and there's increased interest in individuals from multidisciplinary teams getting involved in large-scale data science and administrative data research. So I'm optimistic about what the next 10 years will bring. More real-time data, because at the minute we're looking at lots of data sets that are not concurrent. So I feel like we're getting towards more real-time data, and that to me will allow us to answer a bunch of questions, not only about individual patient experiences, but also for things like evaluating interventions really quickly, where in the past RCTs and intervention research has taken a very long time. This is a mechanism we can use to do things really quickly and be like, that's not working, let's try something new, in order to target the correct care to the individuals and to learn an awful lot more about what interventions actually work.
Like the real-time data question is interesting, isn't it? Because in terms of like being really responsive and having an immediate impact, it's really important. But, so during COVID, I was part of a group where we set up real-time suicide surveillance, suspected suicide surveillance. And there are huge issues about how the data is collected and quality of it. And what that means is, so people feel very, they like real-time data, they want to respond to it. But in actual fact, the quality issues mean that we won't always go down the evidence-based path. I think we're a long time away from when, real-time data will be of a quality that I would feel entirely comfortable with us acting on. And I think, but people respond to it in a way. People want to do things in response to the RTSSS system in a way that they never do when you're talking about sustained trends from ONS data over years. And I think there is a slight tension in there that we should always be aware of when we're pushing for it.
Can I respond? I think it depends on the question you're asking and the outcome you're interested in. Absolutely, there are data quality issues, but things like engagement with primary care, after a particular intervention, are you still showing up to your GP? Are you still showing up to emergency departments? Where are you getting services from? We can get that quickly and accurately. Information like, has an individual died by suicide? We know there's long time delays with that. Information like trying to identify mental health conditions using prescription medication uptake has issues all the time, and we'll have issues in real-time data as well. But I think real-time data can and will be useful soon in this 10-year time frame, but for particular research questions.
So during COVID, because this is a really topical issue at the moment, isn't it? So during COVID, the feeding streams of routinely collected healthcare data became very fast because we had to respond. But then, and we all have it when we work with routine data, isn't it? Is when you go back to it, it's changed a little. Whereas when it's being fed really quickly, it changed quite a lot. So I absolutely, unsurprisingly, we absolutely agree with each other. But I do think that there's an issue there that we are going to have to unpick.
Two questions.
Hi, I'm Sarah. I'm working as a machine learning analyst in Nan's team. Just to touch on the digital footprint and real-time data. During COVID, I was in Seoul, Korea, and what the government is, they used real-time data, digital footprints such as cell phone rings and credit card purchases to track individuals, and doing so, we were able to get updates and notification for each clusters, depending on your neighborhood and stuff. Doing that, Korea had one of the lowest rates when it came to COVID death and the risk of getting COVID. But the culture in the UK, I see that it's very different. The public here, I can just imagine that if you were to propose the same idea here, I can imagine the public outcry about the concern about the digital privacy. So how would you propose that we educate the public about how we manage data, and how can we actually use the data to further the health of overall public?
Can I start with a suggestion? And I've said this a few panel sessions over the last 5 odd years, And I proposed it to UKRI in the response to a consultation review they asked me to do. I think we need to get data science on the national curriculum. It's there in pieces, but if we want public understanding and acceptability and trust in what we're going to do, we can do lots of different bits of engagement and influence different communities, but to get a population shift in understanding, and understanding is a driver of trust, then we need to get much more onto the national curriculum and systematic education about the safeguards around data science, people's rights, the fact that ethics is considered in the way in which we work, the fact that increasingly we've got public involvement at a meaningful level in the way in which we work, and then what the benefits are driving. I don't think we'd ever get to the point where the UK public would necessarily accept what the Korean public would think. That's a much bigger issue, but that's sort of like, I suppose that sort of like how ingrained data is becoming in society. That's a global phenomenon, and it's triggering different sort of emotions in different countries based on traditional ways of thinking. And it is quite a libertarian country, this one. So it's, the actual way in which interventions will manifest will be different, but I think it all comes, the core benefits will be amplified through widespread public understanding.
The other a quick comment while you're passing it over is that, I mean, the UK used to be thought of fairly data poor back in the day compared to everyone. If wanted big data, they went to Nordic countries, particularly certainly for mental health, and there was very little resource in the UK, and that's changed quite recently, sort of within maybe 10, 15 years or 20 years maybe. So these things do change, and it seems to have, I mean, obviously there's been mistakes along the way and public outcries about usually primary care records and things, but largely with the data infrastructure we've got now has happened fairly uncontroversially compared to a lot of European neighbours. I think they're changing, but I mean, I remember 5-10 years ago being told that Germany, France, there's no way this sort of thing was going to happen, the sort of data infrastructure we've got now. I think it's changing in those countries, and they're beginning to move in that direction. But countries always, and nations move at different speeds. And we are actually, it's quite strange actually, because if you'd asked me as a trainee, would the UK be in this situation, I'd have said not. I'd have said we'd still be going off to Denmark and Sweden to do our analyses. But
sorry. I think it depends what you mean by countries as well, because I don't think the UK is homogenous, and I just moved back to Cardiff from Cambridge. I think it's culturally varies in different parts of the country. But I think there is a bit of mistrust in some areas. Like one of the last things I was doing in Cambridge, I was chatting a bit with Sacha Baron Cohen at the Autism Centre there, and there's a huge mistrust of their work amongst the autistic community, and as an autistic person you're sort of asking, what can we do about this? And I think to a degree it's sort of partly education. I don't think in that case it's just education. I think trust is really important as well. But I think that psychoeducation on that personal level, that in terms of this is why we want to collect this data and this is what it will be used for, is really useful. We've found that a lot with the genetics initiative for eating disorders. We do social media posts about what will we use your data for? Why are we collecting genetic information? And I think that very often when people understand that, there isn't a problem at all. But I think most of all, if they understand the benefit, and they maybe see a benefit rather than just a proposed hypothetical benefit, then people tend to be much more sort of on board with it. And I suppose people's stories of this is how it actually benefited me could be really useful.
Yeah, just to add briefly to that, I completely agree. I think my response is going to be education and engagement, that it's not just educating individuals from a very early age about sort of data literacy, but also engaging on multiple levels, and one being the fantastic research that already exists out there, the things that have changed policy, the things that helped us develop our understanding of COVID and sort of manage that pandemic came from administrative data. How much do we promote that? How much do we say, this came from administrative data, you wouldn't have known this without this linkage? And people will then be like, oh, because the media gets to hear the results, but not the methods behind it. And it's more then, like I mentioned to you, about the onus on us to promote more and to be doing the right engagement. And in Northern Ireland, we have a Northern Ireland Public Data Panel, and we're setting up an all-party group, which is with the Stormont executives, so with your government, about public data usage. And the idea then is to have those conversations with the policymakers in charge and to help engage those guys to share the information at a national level when there's good news stories, because I think the best way is to say, we've done this, here's where it works for you and for us.
Like really selling it, I suppose. And I think people generally want to do stuff that's going to be helpful, not just for themselves, but maybe like for others, and like contribute their own data towards something that they know like will be actually useful. I have a genetic condition myself, got myopathic Ehlers-Danlos syndrome, which is like one of the very rare types, and I had the genetic test done, and they said I've got this very strange mutation on the collagen 12A or whatever that hardly anybody has got, and they said to me like, okay, do you want to opt in or out of us keeping a record of this so that we can compare with like, you know, population databases and all this kind of stuff and look at characteristics? And I was like, yes, please sign me up to everything. Do all the studies that you can on me, because like it might help somebody else in that situation. And I think people are altruistic in that kind of way and do want to share something if they understand the benefit. But, you know, quite rightly, people might be suspicious and think it's going to be sold off to so-and-so, you know.
But just touching on the point about not telling enough about the good stories, I think is a crucial one, actually, because those apply to data science, to genomics. So many of the discoveries have relied upon people sharing their data, and we do need to make a better case for that.
I completely agree. I think I love the idea of it built into the national curriculum. I mean, I think they're learning Python now in primary school, so maybe they need to be doing the other stuff. And I completely agree about the good stories as well. You know, we don't do enough of it. I suppose part of me also wonders, though, if we should be thinking a bit critically about the bad stories. So the stuff about Palantir taking over NHS data, I mean, that concerns me, you know, and so there's been a kind of lack of an honest national conversation about how our data is being used and what safety guards we should be building in so that the public are comfortable with their data being used for research. And there are other places like kind of, again, the Nordic countries, they seem to be so trusting and happy for their data to be used for, and they have been for decades. But from what I understand, I don't know if anybody's here from any of those countries, but from what I understand, there's some very, very strict guidance around how that data is used, which I don't think we've yet established in the UK. And maybe that's something that needs to be thought about if we're sort of honest about you know, the application of data for public benefit.
Yeah, hi, I'm Katrina from King's. I suppose I wanted to bring a slightly different aspect and say that in kind of 5 or 10 years' time, I'm hoping that we're going to have continued all of these databases, because certainly in a lot of work I've done, the biological model of psychiatry has been criticised because it wants to get patients not having symptoms. That's the only thing that's important. They go on as many antipsychotics as necessary to get rid of the symptoms. Whereas actually, it's more a lifelong model of engaging with different things, managing to keep social relationships, all of those things. So when we talk about getting administrative and real-time data to guide treatments, that's where I begin to go, oh, let's not fall back into that same trap of saying, we can treat this, we can make this better, therefore that's what we should be doing. But actually thinking about people who have a lifetime of either one mental disorder or susceptibility to lots of different mental disorders. So how can we get data science up for that challenge of actually following through? I mean, I think
Say we're near the end of the session, so sort of an answer each.
The idea of the real-time data to direct treatments is one aspect of the real-time data, but also as predictive modelling for risk factors for individuals who may be going down different trajectories where illnesses are getting more severe or they're becoming at risk of illnesses that they haven't been diagnosed with before, and you can do sort of pre-diagnosis interventions or preventative measures. not just always responsive reactions with the data. In terms of the longitudinal aspect, I'll let these guys answer that.
So I agree in part, but not in part as well. I think, being able to develop new treatments doesn't mean that you're concentrating, the target for that treatment is the symptoms. The target for that treatment can be anything. And I think it is bloody important that we develop better and new treatments for these conditions. But I take on board exactly what you say as well. So we've just started an MRC program grant actually, but looking at the genomics, not of symptoms, but of outcomes. So thinking about functional outcomes, and this was developed with people with lived experience and what matters to them. So avoiding admissions to hospital, relationships and employment were the three areas that were most important to them. There's challenges there, because how you assess those outcomes is not decided within the field, as far as I can tell anyway, and so we need to do better in that respect. But we definitely do need to move beyond the solely symptom or diagnostic focus.
Yeah, I think that we often say, as maybe particularly in eating disorders, coming back to that recovery is not very well defined, and I do think that it is kind of subjective, and there's, on the one hand, the eradication of symptoms completely, is that recovery, or is it about actually supporting mental health as opposed to getting rid of mental illness? I think that will be individually decided. But on the other hand, I kind of don't agree in that. Just personally, I would be quite happy with the eradication of symptoms in my own case. That would be great. So I suppose it's what are individuals hoping for as well, and what are their own priorities. So I would, just as a simple thing to say to that is, well, let that be guided by the people with lived experience in terms of what they want to see as an outcome. Is it that they just don't want to be ill and then build their own life from there, completely outside of services and clinical settings, or is it that actually there's a big role for those treatment providers in quality of life and whatever those things are for them? So when you ask, that's what we're doing in the research that I'm doing, that we're asking people, what does that look like for you? And it is very different, and I think there are some themes around relationships and meaningful activity and this kind of stuff, and I think data has as much role in that as the sort of symptom side.
I think I completely agree. I think sort of thinking about co-producing the outcomes with people with those conditions and understanding what's important for them within the context of that condition seems to be absolutely key here. But I guess then the challenge is, how do we capture those outcomes in data? And there are ways to do that, but I think it's a bigger sort of process, isn't it?
It's a really stimulating question, and the thought train which has been going through my head as the others have spoken is, in the longitudinal cohort world, we've collected millions of data items with all sorts of questions, but I think if you piled them all into a bucket of negative symptoms and outcomes and feelings versus a bucket of positive, happy outcomes, or even a bucket of neutral outcomes in the middle, you'd have virtually all of it in the negative, and that's got to be linked to the policy agenda and the funding stream. So somehow a more strategic push as a community to think about collecting positive outcomes as well would help from the data perspective. I know that was only a sub-dimension of what you asked, but yeah, really, really stimulating question.
I think, yes, to round off, I think that's very nicely brings us sort of full circle, because we began talking about the need to kind of integrate these sort of different streams, the biological, whether you want to see the biological as the medicine someone is taking, and the social, whether you want to see that as the kind of wider outcomes that people are trying to receive and or trying to attain. And I think that, I think that you can't talk about sort of people's experience without integrating both of those together, and so hence the future, it has to be data, at least in our small field of data science, it has to be that sort of multiple data sources pulled together, being able to track someone over long periods of time through the different data sets they appear in. One data set is never going to be enough, and there might be some means of at least modelling someone's longer term trajectory, which I think is sort of, what it might at least begin to get at Katrina's question there. And I had to write an editorial not that long ago on there's an interesting study that was done in Sweden on obsessive compulsive disorder. It was interesting. Partly it was interesting because there were it was a 3-generation authorship, although the older person had died, but it was kind of grandfather, father, son, all co-authors on it, which I'd been encouraging one of them to kind of do this for a long time. Please publish as 3 authors together. And they did, and it was basically some people with obsessive compulsive disorder recruited a long time ago who were successfully followed up long time afterwards. And it was amazing seeing how much things had changed for people. And these were all quite severe diagnoses. An awful lot had got better. And an awful lot had got spontaneously better because there wasn't much treatment around back in the 1950s or whenever it was they were recruited. And I felt it sort of provided an important perspective, both as a clinician, because clinicians always tend to see people in their crises, and you assume, therefore, that because someone's severe now, they're always going to have severe problems, which isn't the true. But also for researchers, because we tend to focus on these sort of rather narrow periods of time and the crisis and the negative outcomes. And I think these that was only going to be possible because they'd got this hugely long, longitudinal and good follow-up, which naturally it came from Sweden, of course, where they can do this sort of thing. But I think it gives that sort of, it gave to me a more real message of what data science could be, and how much it sort of alters the way you start thinking about mental health as a kind of sort of, the longer term perspective that we often don't get. Anyway, that was just some rambling. But thanks very much indeed to all panel members and to everyone who's contributed. I thought that was a really sort of good session, covered a lot of ground, and was really excellent to have. Thank you. And we're off for tea now.